It's wonderful that you take your time to listen and watch this webinar about postpartum physiotherapy, diagnostic, and therapy with a maple probe. And I appreciate this, that you take your time. So I'm working with maple since 2015, and so I have seen many patients. And during the time before, when I started, I thought it's a very good thing to work on it because you have this particular opportunities. But in the meanwhile, I'm using it as a diagnostic tool as well. And all patients are really very thankful because suddenly they can see what happened. And I'm working at the Pelvic Floor Center in Berlin, the German Pelvic Floor Center. I'm the owner and the founder of the practice there. We are a corporation like all pelvic floor centers, and working with a few disciplines like urogynecology, urology, the radiology, the proctologist, and we have nutritionists, and yeah, that's very good. And it's almost a big discussion during the pelvic floor conference. On my other part is I'm a part of the endometriosis center in the Charité with Professor Mexner, and for that reason I'm here in Bucharest because at the European Endometriosis Congress, and in autumn we have an endometriosis webinar as well. And I'm teaching also at the Alice Salomon University of Applied Science in Berlin, physiotherapy students. And yeah, so, and I give Maple webinars. So welcome here. And we have it really takes time. Sorry, please. There we are. So what I like to talk to you with today, the pelvic floor muscles during pregnancy. It's important to know what's happened on the time before delivery. Then the study situation. What about birth injuries? Which birth injuries do we account postpartum? And the Maple procedure about this. Why Maple? Then I would like to introduce you to the pelvic floor Maple check and about some examples: treatment, postpartum stress, urinary incontinence, postpartum fecal incontinence, pelvic floor pain, and pelvic floor weakness, all postpartum. And then I have a small summary, and then we have time for questions, but you're very welcome to ask if you don't understand anything, or yeah, whatever. So if you have a question, don't hesitate. The pelvic floor muscles during pregnancy, it's quite easy. These muscles come under increased strain due to the hormonal changes and the growing baby. And we all see it with the posture, and the weight bearing will change, and it leads to weakening and dysfunction. The prevalence of postpartum urinary incontinence, and now I see I missed one word, so 21.9% of women with experienced urinary incontinence in the postpartum period, and 26% of all women who gave birth have it afterwards. So that's really a lot. It's 1 of 5 and 1 of 4. But it's not so common talking about it, and we really need to carry on with it. The negative effects on the psychological and social dimensions of women's health are really hard and bothering them. So the substantially impacts of the psychophysical well-being of women is important to see as well. And we have to keep it in our mind when we start with our treatment. There are risk factors, of course. The cesarean delivery is not the solution for everything, but it's a protective factor against PPU, but only the primary, not the secondary cesarean delivery. So if you're over 35, multiparity, neonatal weight over 4 kilograms, a perineal dystonia, and history of incontinence-related pathology, or a preconception, a BMI over 24 kilograms. And there's something the WHO recommending 150 minute sports during pregnancy. Excuse me, ask your patients if they are doing it. The historical pelvic surgical procedures and protracted second stage of labor. So this all are significant risk factors for the PPU. And this we have also to keep in our mind when we treat the patient. Birth injuries, how many times they're happening, I have here a little statistical. So if we go to the advanced maternal age, it's again one of 5 women. So we have to think about it because the pelvic floor will change, and we have to see what they are able to do. So the infant conditions are also a big part. The diabetes during pregnancy, it's only 7 to 8 of pregnancies. Maternal infections, obesity, 1 of 4 pregnant women. So that's really a lot. What injuries we see, or what we have to cooperate afterwards, that's the vaginal tears, the ruptured uterus, the postpartum hemorrhage, the pelvic floor dysfunction. That's a very important thing. What we can give them a solution with a really good, a good identification where is the problem located. The oasis, pudendal neural. Oh, sorry, I have to drink the irritation of the pudendal nerve, and very rarely a fistula. But I think the vaginal tears, especially the 3rd and 4th degree, it's very important. So why maple? So it's a very important part for our differentiated therapy, but it's almost included the medical history, the social situation, our physiotherapy findings, like posture, like the vaginal and rectal palpation, and then we can go for a differentiated EMG and therapy. We have to talk about with the patient why it's important for you. What is an EMG? It's a measuring of the activity of the bioelectric activity from the muscle, not more. It doesn't tell you how powerful it is, but during the EMG you can see, is it a slow or very fast contraction? Can they hold or fall down? So we will talk about it in a minute. That's maple, and I'm well prepared with all my things here. I have one maple that you see it next to my finger. I think you can see it. And when you place it, it has to be like you see there. That's my example. And you put it on here, and to be sure that you have this tunnel view, and at the end, this grid, you have to be very, very clear to the patient. It has to be like this. So on the other hand, we have not the right result. Here you can see we have then this grid and the anterior, posterior, left and right, and again my finger next to it. And I can tell you also for a lot of endometriosis and pain patients, it's possible. So when we can palpate, maple is usable. Here you can see it changing. You can see what part will be shown on the grid, and this is verified via MRIs by Petra Vorham van der Zaan. And here you have this overview from the muscles. And I think it's very important because all of us knows that the puborectalis is very important for the very good continence. And in the meanwhile, this is verified as well, the posterior part. And another thing is the pubococcygiosis and the iliococcygiosis, they are stabilizing the posterior wall of the vagina. So that's very important as a support for prolapse situation. And it's also important for very good and sexuality and orgasm for the women. Anally, you can see also, and this is a very important part for the stool incontinence and also the puborectalis. And during defecation, the puborectalis has to be able to relax. That's important. And if we think about the internal sphincter, then we know we can't train it actively, but we can give them a stimulation to come back to the brain. So the pelvic floor maple check, what does the individual findings show? So I explained already what does an EMG shows, but what should I look for? And should I look for symmetry or asymmetry? Should I have more focus to the because my patient told me I'm looking for very more satisfying sexuality. So maybe I should focus on the iliococcygiosis and pubococcygiosis. No, that we don't want. We would like to have a very nice overview, symmetrical, and our body loves the mid-range. Yeah, we are not able to go through a day when we powering the whole day. We need almost mid-range. Then we have still opportunities for very big power when it's needed, like when you are running or coughing, you know. So I'm looking for a nice, good contractility or an EMG result. And our finger can palpate a lot, and also we can verify it with an EMG because then we can send the patient on a document what's changing. So they're happy with us, they will feel it, they have no leakage anymore, they have no pain anymore, but it's also nice to have it on a document. So we go for symmetry, but does the symptoms match the muscle status? And that's something we can't tell because an EMG is only telling the muscle is working, and that's we have almost to be in our mind. So you should almost palpate, see, you have to ask, you have to give the patient an opportunity to test it. But if you feel weakness or if you see in the EMG and discoordination, then it's wonderful because then you can go and work on it. So the overload will be shown on the EMG and the trigger point can be shown. But how is the trigger point be shown? It is like a trigger point has not this middle range opportunity. A trigger point has this going up and go very, very fast down again. And with the grid, you have the grid, and you can see also on the EMG diagram, if it's going up and down, and you can test it for each muscle. So you can really find out where do you have to treat. So then I can find out which muscles to weak, which is overloaded, and just adding information, the trigger point has to be verified by palpation, and the EMG can give you an idea in the function. So it's one adding to the diagnostic for trigger point, but this is an extra webinar. So which muscles to weak and which is overloaded, and I can train them separately. I can stimulate them separately. That's so good, because I don't want a muscle who is already overloaded to give more impact. It works not. And in the meanwhile, I realized it's almost better to stimulate the rest, to give them support, so the other muscle who's good working and good cooperating get less. So how do I deal with it therapeutically? I already told you, and it's important to see what's the patient able to do. So I really love it to give a patient just a certain part to train. So the part who's not very good, so they get electrical stimulation to be aware where do I have to go for, and then we go for just two lines of the grid, and then they can train, and I tell them this you have to train at home as well. So how do I train? It's almost depending on the situation of my patient. So there are recommendations, but it's important what can the patient do. And I have some patients that tell me, I don't mind. I come for half a year to Maple once a week because at home I don't do anything. And everybody of us has this little things that we just don't like to do. But if we have an appointment, we have to go somewhere, we really go for it. And of course, I can understand it in a way. So, and then where do I stimulate? I already said with pain, you can go and reduce the pain for this point of pain. And that's a very good thing with Maple. You can really work on the point of problem or the point of dysfunction. And also, I will stimulate all muscles who are weak. And I won't relax a muscle who's overloading when it's not painful. Yeah, and for that reason, we do before Maple use or before in general, we're using an EMG, we do our palpation. That's important. We are the people for the muscles, and that's just a normal muscle test. Not for patients who are painful, patients who say, no, I really don't want a palpation, and these things are important. That's just the optimal. I'm not telling you do it with each patient and talk a patient into a vaginal or EMG investigation. No, don't do that. You're just offering all opportunities, and we have other opportunities to find out how is the muscle working. But the optimal thing is before an EMG, we do a palpation. So that's really, please have this almost in your mind. Yeah, there are many reasons why women or men also doesn't want it, and we have to accept it, and also we have to expect that patients are, yeah, they have had maybe just bad experiences. So this is an example of a postpartum stress urinary incontinence patient. She came first the 25th of April. She has two deliveries already, and We see here the resting tone, and we can see 2.6, but here's a bit darker, and this is her own grid and result. And if you compare it with other patients who are in the same age, so that's a color view. I have to move you a bit up here. You can see if you look only at this, and if you are one of the people who say, oh, yeah, it's a darker part, so it's hypertone and maybe it's a trigger point. But if you compare, no, not really. This part is weak. Here's a lot of weakness. And if you compare, and that's something, and she has no pain. Yeah, that's important. So almost go back to the history. She has no pain, but she is her second baby, and she loves it to have the baby on one arm and overload a bit, or train, in her case, more one part of the muscles. So it's this side, and you can see. So what would we do? I would do to stimulate this part, and so I would stimulate the external two, and then I would go for these parts. So twice a stimulation, the whole external 1 and 2, and then the right and the posterior one, to become more more power and more stimulation and more connection to the brain, between brain and pelvic floor. And then she has to work on it. And we could see also each single contraction. I show you later at the end one PDF and explain a few things for that as well. But if you look now to 5 microvolt and here 6.7, and she's not working a lot with extra muscles, so it's not a lot. Yeah, so it's good that she's training. And this patient, she's still coming now every second week. And what I do almost is I stand up because I have prepared. I love it when patients able to work on it, and then they have the probe in, have the clothes on, and then the maple is hanging, and they can work in a standing position with the gravity as a strengthening like daily life. So that's very good. And also you can see how do they work, and it's harder. They almost tell me it's harder in a standing position. And for that reason, I say, okay, the stimulation we do in a lying position, so you can concentrate more. And the contraction, we work on it in a standing position. So, moment. Then the postpartum stool incontinence, it's important to think about if they have a T degree of 3 or 4, we won't palpate. In our clinic, we won't palpate before 6 weeks after surgery. And sometimes when patients have really hard problems, I'm working with them vaginally. That's also okay. And here we have a patient from the 18th March of 24 in the beginning. So unfortunately, no, it's not unfortunately, but I gave you both impressions. So, and then at the 30th of May, so after 2.5 months, we can see how she improved. And you can see here it was very weak, and you can just compare numbers. So the EMG was 12.6 and here 19.4. And this is in a standing position. Yeah, even with the stool incontinence, she said, now I have to work on it. Usually we do it on lying on side, but she said, now I'd like to work on it. So for that reason, the highest is 42, but she became really good in the meanwhile. And here you can see there was nothing, you know. And the fast contractions, you can see 15 in a standing position, 24, and here we have 13.4, 27.3. So here in a lying position, she has done a lot of other muscles as well, so they help the gluteus. But you can also see it looks more homogeneous. So that's what I wanted to show you. And also the relaxing tone, you see it's 5.1 and here 5.0, but this is okay with the stool. So that's very fine, but you can see also that changed a few things. You know, it's a different symmetrical overview. And that's something you have to learn. And yesterday there was a very, very great talk, a very good presentation of a gynecologist from Norway. And she said, we have to respect our learning curve. So if you start with something, you have to respect your own learning curve, because first of all, it's the same with the patient. First of all, they have to become aware there is a problem. Then we have to explain them how are the muscles working and how things are connecting. And the same is with us. If you have seen a few patients, if you palpate a few patients, I guess most of you will palpate. It takes 5 years after you're able to go into a very good research to see, okay, this is this differentiation. And so it's important to accept your learning curve. For that reason, I gave you these two pictures. And I taught you in the beginning, we look for symmetrically. And if you just look for the symmetrical, this homogene situation, you will see it's much better. So that's important. And of course, all my patients, I try very hard to make them doing at home exercises. I give them also exercises for the transversus abdominis, for the pelvic floor, for the pelvic girdle, and for very good hip rotators and everything. So for all these things we have to look to. So for that reason, it's almost 1 hour. And now we have the pelvic pain situation. And you can see here, it's the 14th of May 21 and the 22nd September of 22. And I have to move this again. And you can see, wow, that's a big difference. But with this patient, she came after her third baby. Yeah, it was the third baby. She has had a very hard stool incontinence in the beginning, and then she has had trigger points. And in really here was a trigger point. These iliococcygiosis, pubococcygiosis, of course, it's the most stretched muscle during delivery. And now you can see this related also in a very good intensity, and she became really very strong. So that's very good. So the power became improved a lot. And if you look, 4.2 in the relaxation tone, so doing nothing. And here is it but I think she was coughing around 7.9. But you can see here still a bit more power, but she's one of these patients who have this very powerful situations. She have a very good, very strong skin and tonicity. So for that reason, I really don't mind. I can see there's still more inside in the deep with the Iliococcus pubococcus, but you can see when she's working, it's still now it's from a 8.4 to a 9.5. So I theory really don't have to care about it. And here I go from a 9 to a 18, so it's double. And from the pelvic floor perfect scheme, she was really weak. So this patient who has a high tonicity in her whole body, her pelvic floor was really a 1 to 2. She could do it, but it was almost very, very high. And now she is with the 4. So she's really good and very happy. And that was the pelvic pain. And in the treatment, I just go back, in the treatment, I was supporting with electrical stimulation everything what was not weak, what was weak and not the trigger point, because with the trigger points, it's my treatment. You can choose something else. I did almost before the trigger point treatment, then we waited a moment, then we gave a stimulation to the other muscles so the trigger point muscle could relax, and she got stimulation to the others, and then we made the training. And during the training, I took it almost out, because the trigger point comes because there's an overload to this muscle, and this muscle said, yeah, I do it. And it's, even if you focus to the other, it's still active. And she was a part of my research, and at the end, after 4 treatments, the trigger points are really gone. So then we have this postpartum pelvic floor weakness. I have also a patient from the 25th of April. And yeah, don't be shocked. It's no, it's the wrong picture. I put twice the same in. Sorry for that, but it doesn't matter. I wanted to give you 2 because this one has here again a dark situation. And if you look at the curve, the EMG curve, you will see it's going up and very, very, very slow down. And here the same, it's like I showed later to you in the PDF, and it's going up and up and down and up and down. So there's no good coordination, and she was really weak. She has really only a 2 out of 5 and the perfect, and not a very good endurance. So she was working, and I told her, just work on a middle range, don't work so hard. And also we treated the trigger points. She is weak and has trigger points, and so we can see. But I have another one where there are some patients that would the other one. Here's nothing. Here is the 2.0, and this part is coming a bit darker with a 3.5, and this one is coming with a 4.5, and everything is just gray, just gray. And if you look then at the other one, it's really dark blue. So compare with all women afterwards. But that's an important thing. She's working hard, she's getting better. But a weakness, I almost go for an electrical stimulation for the weak parts. With this patient, mostly the right side and the posterior part, and the second stimulation, the surrounding the bulbus spongiosus, and so grid 1 and 2 from externally, and then I let her train. And this is not painful. It looks like, no, this has been also trigger point, so no, she is much better. But it's important, if it's weak, I train almost in 2 sessions. I train almost, because I realized that was my personal learning curve. I realized if you stimulate the 3 grids from outside, so 1, 2, 3, and then again 1, 2, 3, it feels different. Just try it once. It feels different, and the current is different to tolerate for the patient. That I felt very interesting, because in the beginning, when I have this, even with actively contractions, I almost felt, okay, then we can do it, and she has more time to train. Now it makes a difference. So that's my personal learning curve after 9 years. And now I go to the in a second to the PDF and explain a few things. I'm a bit anxious if I go out. So the resume before the PDF, so MAPLE shows EMG findings and enables us for an individualized therapy tailored to the patient medical history. And the therapy goal, the PDF shows very well for therapy and documentation and progression. So especially if the desire to have children is not yet completed, then it's important to give them the opportunity to come half a year later for a check. That does many patients try to do. And so that's important. And it's important for us as well, because it's our learning curve. Now I go once out. Right. So now we have this PDF, and the PDF, so for that reason, is my name on, because it's not me, but my name is on, because this is what you can give your patients. And there's the name and everything, and the patient number. And you see, that was the resting mode. Vaginally, and here you have the graphic as well. And you see, well, right and left is a differentiation, and this is something very nice. You can see how does it work, and you can see here with the fast contractions, it's going quite high, so we have to change here a bit, and the relaxation is getting worse after a while. And you can see the puborectalis, not the puborectalis, also the puborectalis, but the posterior part doesn't work properly. And in the endurance, or it's later on, it's again. So that's telling us a lot. And now we can see the endurance. It looks like this here as well. You can see, and you can see the relaxation does take time, but almost the posterior part is not working well. And then what I told you, then I give patients the training, and they can't see this. They have to focus to all the parts who are not very, very good. So that's a solution for training. And this is something we need. We need, especially after vaginal delivery, we need to stabilize the posterior wall of the vagina, so that we can wonderful see. And you see here, it's not so straight anymore. So if you watch just different parts, you have a difference in the EMG graphic. So here as well, you can see there are different working. And now I think it's another day. And here can you see all single contractions. So, and you can have this each day you worked with the patient. So what I give them almost, it is a very good situation to see in the beginning when you have here, it's working, but not enough. And you can have it also in color, but I think for patients, I like to give them the individual result. But you can see there was not concentrated enough on anything, but they just couldn't do it. And afterwards, after the training, it became better, and it's quite continuously the contraction. And the same here also. And the other contraction. So that was a continuous situation. And here the endurance, we have done only 4 contractions, you can also see. So something to do, but it's something for home. I tell this patient, think about lifting your anus to your symphysis, lifting your anus, try to go really from the posterior part. This has to be stabilized. The rest has to be trained, but this has to be stabilized. And there we have to go for focus, and there we will stimulate. And if you have a woman postpartum, you can see it so differentiated, and you can really look how can I help her. So now I'm very happy to have shown you everything, and I was very happy that everything worked out well. And now it's time for questions.
Yeah, that was the one. Thank you very much, Sonja, for the very nice presentation. There was one question coming in regarding this overview you mentioned, this reporting function. This can be generated in the Maple app in the beginning in the history part. You can make a PDF file like this one to be saved or to show to the patient or to share with the medical doctors.
And you send it to per email.
Yes, you can do. Yes, yeah. There was one other question. Can you read it, Sonja? Thank you for the presentation and practical examples regarding NMES. Does the Maple device have already established muscle stimulation parameters, or you can change manually? Change the current, etc.
Yeah, you you have options, and you can change it. So they give you some options, and you can change it manual as well. Both. There are suggestions for pain, for urge, for there are 2 for pain, 1 for urge, and 1 for weakness, and also you can decide what you would like to do. Any more?
Are there more questions? I don't think so.
Okay, so if you if you have any questions, I'm the head of the German special interest group for electrical therapy and with Physio Germany, and Novocare is a partner of us, and some other manufacturers as well. And there are many things on the website. It's For people who are in German, it's at this time only in German available, but we will change it in English as well. There are many informations, and we will start with the Maple Club soon. And the Maple Club will offer once in a quarter, so 4 times a year, a 1-hour session to share patients and to answer questions or to get used to a few things. But if you have any questions, just send me an email, and that's fine. So if you go on it, there's maybe, can you write it in the chat, the website? Oh no, I
Yeah,
don't know.
sure.
Yeah,
Yeah, I can.
www.elektrotherapie-deutschland.de.